give you any repeats, so you have to go back to her office every month, which is becoming a hassle. Patient comes to the pharmacy and says, I need to speak with the pharmacist. I don't know why, but my doctor will only give me 120 tablets of oxycodone per month. So you as a pharmacist, a regular patient approaches the cash register and asks to speak with the pharmacist. When you check their medication profile, you see they're currently taking the following prescriptions from Dr. Bailey: Ramipril 10, atorvastatin 10, and oxycodone 5 milligrams, acetaminophen 325 milligrams, 1 tablet QID PRN. When you check further back, you see that previously Dr. Kendall was prescribed the oxycodone, 1 to 2 tablets QID PRN to dispense 720 tablets and lots of 240 every 30 days. So how would you interact with this patient if you only have 10 minutes? So what are some issues that you might want to discuss with the patient? So he was taking 8 tablets per day, but it got cut down to 4 tablets per day. What are things that we've discussed already? So he's taking it for a hockey injury. Does anybody have any thoughts? So a couple things. What are some questions that we want to ask him? Okay, so Nick has mentioned increased tolerance. Yes, so increased tolerance, we know that he started off with only 3 times a day, 3 tablets per day, went up to 8 tablets per day. May benefit from alternate therapies, NSAIDs, physio. Yeah, so those are great options. So we know he has an injury. We don't know how long ago or what exactly though, but always opioid sparing modalities are an option. So those can include analgesics such as acetaminophen or NSAIDs, physiotherapy. Those are excellent options to help minimize the amount of opioids that they may require. So NSP mentioned is the reduced dose working, experiencing any withdrawal symptoms? Yeah, exactly. So you want to investigate a little bit more into why he's asking for his dose to be going back up again. So is he experiencing pain, increased pain, because he's not being able to take the 8 tablets per day? What type of symptoms is he experiencing exactly? So he might not be experiencing pain. He may be experiencing some opioid withdrawal symptoms. So we discussed about some of those. So that could be some anxiety, dilated pupils, things like that. So you want to ask him what is he experiencing specifically. Should discuss, Abraham mentioned, should discuss reassessment of pain by MD. Exactly. So we know that he was seen by the, this was originally prescribed by his orthopedic surgeon many, many years ago. So maybe, does he even need to be on these opioids? So that's the question we already talked about. So is there an appropriate indication, right? So often we see people prescribe opioids for indications that don't, opioids aren't an option or appropriate indication. So things such as fibromyalgia or chronic migraines. So again, we want to kind of go into what is his actual injury and is our opioids actually indicated? So what if he's having neuropathic pain? What are options that we can provide to him too? What are some medications that are effective for neuropathic pain? And then also, can somebody mention about what type of opioid is he on? How much is he getting? So what are things that we can talk about with the patient specifically? And then also maybe if somebody can talk about the type of opioid that they're on. What are, if they are indicated for an opioid, what would we suggest if it's a chronic injury? Terry mentioned, what was the reason why the new doctor reduced the dose? What was said at the patient-doctor meeting at the time? Yeah, these are all excellent questions. So again, we're not asking these questions in an accusatory manner. We're just trying to get more information. So again, the doctor may have explained to the patient why they're reducing it. And so if you ask the patient, you know, what was said, you can have more insight into the reasoning behind that. Yeah, and also you can also offer maybe to potentially call the doctor and follow up on behalf of the patient if, you know, maybe the patient was kind of too nervous to bring up certain issues or didn't want to make it seem like they were drug seeking, so they didn't say anything. But you know, yourself as a healthcare provider can have a conversation with the doctor also. So let's assume that the patient has a chronic pain condition. What could we recommend? He was on oxycodone acetaminophen tablets. What would we recommend as an alternative to that? So in this case, he was taking previously up to 8 tablets. So that would be 40 milligrams of oxycodone total in a day, and it was reduced down to 4 tablets, which would be 20 milligrams of oxycodone per day. So what is an alternative if he has an actual chronic pain condition that requires opioid for a long term? Yes, exactly. Okay, Kamal came up with the right answer. Can be switched from to long-acting opioids such as morphine SR. Exactly. So these are good options. So we know that the patient is on oxycodone, which is 20 milligrams oxycodone total. So if we want to switch to something like morphine, we know that morphine is not the same as oxycodone, so we would have to convert it to morphine equivalents. So for example, this would be 20 milligrams of oxycodone, which is equivalent to about 35 milligrams of morphine. But then we already talked about incomplete cross tolerance. So then we know that if we switched him, for example, to morphine SR, then we can actually lower the dose too. So let's say, for example, they wanted to switch to Cadian, we could switch them to maybe 20 milligrams of Cadian, which would be a dose reduction overall in terms of his opioid, a total opioid dose for the day. So again, that would be that would be helpful in multiple areas because we're lowering his overall opioid use. Plus, in theory, we may be able to provide better pain control because he's getting that long-acting opioid release throughout the day rather than having the peaks and spikes of a short-acting medication. Yeah, so yeah, I think that's most of the issues for this situation. If anybody else has any questions or comments, feel free to add them in. But yeah, so again, just to summarize, we want to make sure that there's an appropriate indication, follow up with the doctor, consider switching from short acting to long acting, and lowering the dose as much as possible, and considering other non-opioid options, which can include non-medication options such as physio or medication alternatives such as NSAIDs, acetaminophen, or neuropathic pain agents such as pregabalin, duloxetine, or gabapentin also. Okay, so we'll move on to the next case, which is specific to the second didactic lecture we covered, which is destigmatizing opioid substitution therapy. So this one, the background information is there's a methadone clinic which will be opening up 2 blocks from your pharmacy in 1 month's time. Since there are no other pharmacies within a couple of miles, the administrator at the methadone clinic has asked if you would dispense methadone and buprenorphine naloxone for their patients. Your pharmacy is relatively small in a strip mall near a senior's residence, and you're currently open Monday to Fridays 9 to 5, closed Saturdays, Sundays, and holidays. So how would you approach this? Okay, so let me see. So people may have already had this type of experience, depending on your location and where what type of community you're working in. It may be a smaller community where a methadone clinic or treatment has opened up. So what are some practical issues that you would have to kind of deal with initially for this situation? So the methadone clinic is opening. What are things that you would want to discuss? Or if people already are working in pharmacies associated with clinics, what are some logistics and issues that you have to deal with already? So Terry mentioned need to discuss what hours the clinic is going to be open. Yeah, and Krista kind of mentioning the same thing, and daily dispensing would be difficult. Yeah, so these are some of the logistics we mentioned. You know, as your pharmacy, you're only open Monday to Friday and you close on Saturday, Sunday, and holidays. Does anybody have any recommendations on how you may approach this then? If you want to do daily dispensing, what are some options for you? Yeah, discussing the hours of the clinic is going to be open. Yep, those are excellent. May consider increasing opening hours to Saturday and Sunday. Yeah, so an option may be, and some pharmacies that I know do this, they may have an option to maybe open on Saturday and Sunday for a few hours just to accommodate people with daily dispense dosing. Again, this depends on your pharmacy if you're capable of doing that, but that's always an option. The other option may be guest dosing at another pharmacy if that's possible, but if not, if there's no other pharmacies available, then you may have to send to the clinic to get a designated dispenser at the clinic. Have patients sign a contract to come at specific times. Yep. So this is mentioning about if you're going to be starting to dispense methadone, you want to have a patient agreement contract between you and the patient. You want to have an agreement between the patient and the clinic, and you want to also have an agreement between the clinic and the pharmacy. Talk to your staff to prepare them. Excellent. Yeah. So you want to make sure that everybody in the pharmacy is on board with you starting the decision to start dispensing methadone and possibly buprenorphine at the pharmacy. We talked a lot about stigma, and again, the point that I wanted to bring up is that often you'll find a lot of stigma even between your own colleagues. So some of your own pharmacists, pharmacy technicians, or front store staff at the pharmacy may be opposed to having methadone at your pharmacy. So it's important that you provide information to everybody so everybody's on board with this idea, and to provide education and answer any questions that they may or may not have. Terry mentioned how many patients are being treated daily. Yeah, that's another great question. So again, you want to have an idea of the volume of patients. So again, you can adjust your staff or hours accordingly. If it's just one or two patients, you know, they may be okay just having their medications dispensed with everybody else. If it's going to be a lot of patients, potentially you may want to have a separate waiting area or a private counseling area, because sometimes people may or may not prefer having those areas available. Abraham mentioned may request Sunday carries. Again, yes, that may be an option, but for a lot of people, if they're on daily observed dosing, Sunday carries would not be an option specifically. And obviously, we know that if a patient is not eligible for carries, it's not okay to give a patient a carry if you're closed for that day or on the weekends. Carry your current patients along so they become aware. Yeah, so again, you may want to have a town hall or open information session. Again, if you're working in a small plaza or community, if people hear that you're going to start dispensing methadone, there may be issues or people have concerns about safety. So it's important to answer everybody's concerns and questions about this prior to you opening, so that it minimizes the interruptions that you may experience. Yeah, so NSP has their own personal experience. When I started dispensing, techs and pharmacists were apprehensive about it. 5 years on, most staff are on board and have good relationships with the patients. Yeah, so again, there are a lot of stigmas, misconceptions regarding dispensing methadone. Can methadone dispensing and be challenging? Of course it is. Nobody is saying that it's not challenging. But a lot of times I don't like to necessarily specify it with specific to opioid use or methadone patients? Are there challenging patients regardless of where you work? Of course there are. So, you know, it's how you work with those patients, and I don't want to necessarily attribute it specifically to patients who are on methadone, because generally speaking, most of the methadone patients you're not going to have any issues with. And again, it's important to note that even other pharmacists, if they're not appropriately trained or don't have as much knowledge about it, they're going to be concerned about dispensing methadone. So again, with the appropriate education and training, dispensing methadone is just like any other medication. Yeah, so those are great points. Any other questions, I guess, regarding that? Just as an aside, I guess, is anybody familiar? It's not particularly covered in this course. Any experience with Sublocade, which is the new subcutaneous once a month buprenorphine injection? Has anybody had any experience with that at all? So that's another treatment that's slowly gaining a little bit of traction. So you may see that in your own community or your own practice. It's a sub-Q injection, which is given after a patient has been stabilized on Suboxone for up to 7 days. The only issue, I guess, is that it has to be administered by a healthcare provider, a nurse, or a doctor. So you may be seeing some information about that. So I think that's about it for today. Again, if anybody has any questions, we still have a little bit of time, maybe about 5 minutes left. Feel free to type in questions and I can answer them. Outside of that, thanks everybody for attending this session this morning. Oh yeah, so Nick mentioned the Suboxone Film. So again, that's available too. So similar to the tablet, sublingual tablet. The only issue with that, I guess, at the moment is that it's not covered by the ODB. So I feel like that's the only issue. But again, it's a good alternative. So it's the same idea with the tablet. It's the film can be sublingual or buccal, so it can go on the cheek and dissolve slowly. One potential advantage may be if I'm not sure if you guys are familiar with microdosing. So sometimes we require small doses of buprenorphine for microdosing. So typically we've been quartering tablets, which again sometimes can become a little bit difficult, but with a film, you can, in theory, cut it so you can get a little bit more accurate dose. Yeah, and then I think Fadi will can talk to Saeed about the test. Okay, so yeah, I think we'll wrap it up if nobody else has any other questions. Thanks for attending the session. And again, if you guys have any other questions, feel free to contact us. And hope you guys enjoy the rest of your Sunday afternoon.